because there's overlap between this talk and Friday, I've changed as many slides as I can, and I thought I'd try, as we go along, talk about different things as much as possible. So that's the objective. So this slide just shows improving survival over the last 20 years. And this you know already, so we don't have to talk about. But all around the world, obviously, the prognosis for ALL has steadily improved. That's due to improved chemotherapy, better supportive care, and on the lower part of the slide, there's all the things that have been useful, really, in supportive care terms over the last 10 years. So, okay. So I think, again, everybody in the world bases ALL therapy on 2 to 3 years chemotherapy. I think there's still a debate to how long treatment should be for. I think, I know your St. Jude's protocol treats boys for longer than girls, I think. That's right, isn't it? You give about you give longer treatment for boys than girls with ALL. Yes, yeah, same as us. So do we, which isn't the case in much of mainland Europe. Certainly the German BFM don't do that. And I suppose one of the things we don't know yet is whether the extra treatment is necessary in boys if the beginning of the treatment is intensive enough and appropriate enough. Whether we'll ever get an answer to that, I don't know. And clearly everybody uses induction, some form of intensification. There's a debate that if you use intensification blocks, which everybody does, how many are needed, and I think you generally use 2, and we generally have used 2, but we'll talk about that a little bit. There are issues to do with CNS-directed therapy and with maintenance, and different countries give maintenance in different ways. The main difference being that some countries just give oral mercaptopurine and methotrexate, whereas other countries also give monthly pulses of vincristine and dexamethasone, and continuing intrathecal methotrexate. And what we know is whether or not you have to give continuing pulses of vinc and dex and continuing intrathecals depends on what the first 6 months of treatment is. So the German BFM have shown very clearly that with their initial therapy, there's no need to continue with pulses or intrathecals, which is great, whereas other schedules with somewhat less intensive first 6 months, it's not clear one can safely discontinue those elements of treatment. So in the UK, these are the prognostic factors that we use, and I think generally it would be the same throughout the world. So most groups that have looked at prognostic factors agree that age of diagnosis, white cell count of diagnosis, cytogenetics and response to treatment are important. And quite a few years ago now, when we were thinking of adopting CCG studies or CCG treatment, we analysed the UK data set using age and white cell count, and this just shows how prognostic these are. So the top line shows young patients with a low white count, and the bottom line shows older patients over 10 with a high white cell count, and the other two lines, which are more or less the same, are the remaining patients. So those factors, which are easily measurable at diagnosis, are prognostically very significant. Now, in the 1990s, we realised in the UK that there was something of a problem with the UCAL studies, and although UCAL seemed okay for standard risk patients, there was an increased relapse risk in high-risk patients, which meant that the relapse risk was about 10% higher than it seemed to be in the BFM group and with the CCG using the UCAL studies. And although those patients were often salvageable, so the overall survival was the same, we were worried about the relapse rate. And when we looked at the CCG studies, it wasn't clear what elements of their treatment strategy would make the difference, so we had to adopt the whole protocol. So since 1999, our treatment's been NCI risk-directed, based on CCG 1961, 1991 and 1882, using a 3 or 4 drug induction. And in the 1990s, we developed MRD in the UK, following on the German BFM experience, using PCR, and it's sort of detailed on the bottom of this slide. And we've talked a bit in the last few days about PCR versus flow cytometry for MRD. but we've invested a lot of time and effort and money in developing PCR, so we're not going to change rapidly now. We'll be sticking with PCR. So just to show the risk groups, based on the NCI assessment, and this is obviously different to the St Jude's way of stratifying risk, and this has always been one of the problems with ALL protocols, thank you, that so many groups use slightly different ways of dividing the patients up, and we were talking yesterday about low risk and standard risk and intermediate and high risk, and the terms, because they're different terms in all the study groups, one has to scratch one's head a bit and think about which groups are the same patients. So clearly, for example, TEL-AML1 doesn't appear in this risk stratification, and from the discussions I've had, with the St Jude's-based protocol, TEL-AML1 are a group of patients who are pulled out as being low risk of relapse. So our standard risk here, the young patients, low white cell count, intermediate risk, older patients, higher white cell count, and then when we get the cytogenetics back, which probably with FISH takes about 3 days, with G-banding takes about 9 or 10 days. If the child's got a Philadelphia chromosome, which as you know is only about 2% of the youngest children, they come out into this group. If they have near haploid, which is less than 44 chromosomes, they come out as well. If they have an MLL rearrangement, they come out. Infants we'll talk about later, but they get a separate protocol. And this group that's been recognised recently, first of all in the UK, subsequently confirmed by the BFM in Germany, we've also identified as higher risk of relapse. So basically all of these patients require intensified therapy. So this is just a slide which you don't have to worry about the detail too much, but this shows about the first 6 months of treatment in the CCG-based treatment strategy. So here, about a third of the children are in the lowest, in what we call the standard risk group. So, and they get fairly low intensity treatment with a 3-drug induction, vincristine, dexamethasone, and pegylated asparaginase, which we'll talk about a bit later on. They then get weekly lumbar puncture with intrathecal methotrexate or mercaptopurine. They then go on to a standard maintenance with oral mercaptopurine or methotrexate once a week, monthly vincristine and dexa pulses, and another intrathecal. They get a reinduction or a delayed intensification along here. They get some more maintenance, they get another delayed intensification, and then they go on to maintenance therapy. The intermediate risk children is very similar, but they get anthracycline, and we use daunorubicin, I think you use adriamycin in induction, and they get more consolidation, so they get cyclophosphamide and cytarabine added to the consolidation, otherwise the same treatment. And then finally on regimen C, the most intensive arm, which is for the highest risk patients, it's intensified again by the addition here of 2 Kapitsi regimens using escalating intermediate dose methotrexate without fulinic acid rescue. So that's the basis of the treatment strategy. And because the CCG had shown that response as assessed in the bone marrow in the first 2 weeks has prognostic value, and because the BFM had shown that the prednisolone response had prognostic value, we incorporated treatment response into our assessment of the patients, and we do a bone marrow at day 8 if they're in the intermediate risk group, we do a bone marrow at day 15 if they're in the standard risk group, and if they're a slower response, which means they've got more than 25% blasts in the marrow at those assessment points, they move into the most intensive arm, group C. And that means you're very, very unlucky if you're a standard risk patient to have to go into group C, but it's a bit more likely if you're an intermediate risk patient. So that's the way it works. And this is the event-free survival now, showing all patients treated in the UK since 1997. So the lowest curve is the trial that we started in 1997. And then after 2 years, because we were worrying at this stage about the relapses, it's in 1999 that we changed the CCG approach. So the ALL 97-99 study was different from 97 in that it shifted from a UCAL 11 based approach to a CCG 1882 based approach. And you can see that the outcome got better here, event-free survival. And this is ALL 2003, which is shorter follow-up, but looks like it should be somewhat better again than ALL 97-99. The randomizations in the 97 and the 97-99 protocol were a comparison of dexamethasone against prednisolone as the steroid, and we found that dexamethasone was superior to prednisolone in the doses we used, and also a randomization for thiaguanine against mercaptopurine as maintenance therapy, and we found that thiaguanine was more toxic but no more effective than mercaptopurine, so we don't use it anymore. So when I showed you the last slide, it showed that it appeared that ALL 2003, which is the current study, is better than ALL 97-99, which is of interest because on paper they're more or less the same treatment approach. So this is a forest plot, and the way these work is there's a line down the middle here, and if the block on all these other lines down the side here is right on that line, there's no difference between two treatments. If the block and the distribution is shifted to the left, it means ALL 2003 is superior. If it's shifted to the right, it means that ALL 97-99 was better. And you can see basically for everything, ALL 2003 is superior to ALL 97-99. And that's true for standard risk, high risk patients, it's true for boys and girls, and it's true for T-cell and non-T cell immunophenotypes. And we're interested in T-cell disease because many groups around the world have found that T-cell ALL is a poorer type of ALL than precursor B-cell, and for many years there were debates about how bad was it, and was it the fact that it was T-cell of itself, or was it the fact that T-cell patients were often older boys with higher white cell counts and things. But I think generally T-cell disease is something that people have worried about. So these are the results of ALL 2003 compared to 97-99 for T-cell disease, and you can see that certainly 3 years the event-free survival is 85%. You can see here that most of the patients with T-cell disease have ended up on regimen B, and that's because they're intermediate risk patients, because they tend to be older patients and they tend to have higher white cell counts. And then this box here shows the event-free survival split by white cell count. And you can see that here in the under 10s, the 3-year event-free survival is 89%, and the over 10s, 80%. So there is still an age effect, which we'll talk about a bit more again tomorrow, and that teenagers with T-cell disease and high counts do worse than younger children with high count T-cell disease. But the results are fairly reassuring. And I suppose the other thing about T-cell is really an early relapsing disease. So although the follow-up is not very long here, because T-cell disease, when it's going to relapses earlier than precursor B-cell disease, it's quite likely that this curve won't drop anymore. So it's fairly promising for TALL. So coming back to this issue that ALL 2003 is better, as far as we can see, than ALL 97-99, we tried to work out why that was the case. And as you know, there are all kinds of problems with trying to compare the results in 2 consecutive time periods rather than having a proper randomized study where the treatments are allocated to patients during the same time period. But and because in ALL 97-99 there was this randomization, both for the anti-metabolite, mercaptopurine against thiopurine, and also for dex against pred, we took the patients who had thiaguanine and or prednisolone out of the analysis, so we could just compare the children who had dex and mercaptopurine, which is identical theory to ALL 2003, and the difference was still there. So if it's due to the drug, and I can't say that is definitely due to the drug, the only drug difference is the fact that we use pegylated asparaginase, in ALL 2003 as opposed to native E. coli asparaginase in ALL 97-99. So one of the problems is we've tried to run studies in the UK looking at asparagine depletion, looking at asparaginase antibodies, because you know these are issues really in how best to use the drug. And I don't know why they've been very difficult to do, but we haven't really got any conclusive data on it. And everybody knows that inactivation of asparaginase is a problem, and especially if there's silent inactivation, so patients who don't get allergic responses, but they're breaking down the drug because those patients have a higher relapse rate. So that is a problem. But we haven't actually, we don't monitor every child to see if they've got silent inactivation. But certainly, as far as it goes, we think that if anything's made a difference, it's using PEG asparaginase. It's an expensive drug, but it's far fewer injections, and that makes the children happier. So that's quite good. Okay, so I talked about MRD. In this slide, I'm sure everybody, it's probably the case that most people in the audience know more about MRD than I do, but just to summarize the situation with MRD, and clearly this is all to do with the fact that almost every child has a remission marrow at day 28. So the failure to remit, or the percentage of children who fail to remit by day 28 is only about 1 to 2% now with ALL therapy. So morphology, after the first 2 weeks or so, morphology is no longer a useful way to monitor response to therapy, so you have to use something else. And this just lists the sensitivity of different techniques. So I put cytogenetics can detect one abnormal cell in 1,000. Actually, as far as I can see, it's possible with FISH to go down to about 1 in 1,000 cells. So that's useful. We use PCR here, as it says, which goes down to about, well, certainly down to 10 to the minus 4, 10 to the minus 5. And flow cytometry, which you use here and is obviously used in the States a lot, is not used very much in Europe. So there's a bit of a split really in how people monitor MRD, with Europe being very PCR based and North America and obviously Cairo being very flow cytometry based. And a big advantage is this is very expensive and this is cheap or cheaper. So that's a major advantage really. Okay, so this is just a slide which again people were familiar with, showing how powerful MRD is in indicating prognosis in groups of patients. So down this side here, relapse-free survival, along the bottom here, follow-up, and then just showing the higher the MRD level, the worse the prognosis. Now, one of the things about MRD is it does, obviously, the way we assessed patients and patients' response was fairly clumsy, because things like age and white cell count, obviously they're related in some way to tumour biology, but it's not terribly clear in what way they're related to tumour biology. And then the whole thing of assigning people into risk groups based on morphology, which is a bit subjective because it depends what you call a blast down the microscope. So MRD, in a way, in many ways, is a very powerful tool for assessing risk. And this slide just shows that if you apply MRD to different risk groups of children, even within patients who you think are at high risk of relapse on their clinical features and cytogenetics, you can find patients who are MRD low risk and who will do well, and we'll revisit that later on when we come on to talk about Philadelphia chromosome positive ALL. And similarly, you can find patients who, by the standard criteria, you think are likely to do well, and yet they're MRD high risk and they're likely to fail treatment. So just to look at this group here, you can see these are the high risk patients. And here, at the bottom here, there's about 15% of the children who've cleared their disease really, really well and are very likely to be chemo-curable. Whereas here, it's a small group of patients, it's more in the intermediate. But there are occasional patients who clear their disease well, have low-risk cytogenetics, and yet are doomed to relapse. So we've gotten to the way of thinking that MRD is the most powerful indicator of clinical risk and really overrides more or less every other feature in terms of prognosis. So this is what we've done in ALL 2003. We've known for many years that about half of the patients with ALL are curable with much less treatment than we use nowadays. So if you go back to 1980, which is when I first started as a very, very junior doctor working with children with ALL, in the UK we had a very low intensity protocol called UCAL8, and yet it cured about 55% of the children. And yet all of those children now are given far more intensive treatment that they don't need. So we've been very interested in using MRD to identify children at low risk of relapse and to reduce their treatment. Now this issue is contentious because some groups around the world aren't really interested in reducing treatment very much. Mainly because they're just very, very worried about relapse, so they don't want to do it, and others want to reduce it. So what we're doing is in patients who are MRD negative, we're looking at taking one of the delayed intensifications out. So what that would mean is that we're randomizing one DI against two DIs. And then for children who are MRD high risk, as we call it, we're randomizing them for standard treatment against regimen C, more treatment. And we rather hope that that will help them, and there is some evidence to suggest it probably will, and we think it's almost certain that we'll be able to go down to one delayed intensification in the MRD low-risk group of patients. So that'll change our treatment substantially, probably by next year. So this slide, which I apologised the other day about, and I'll apologise again, is a bit too busy, but the bit you need to concentrate on is the red bit here and the green bit here. So these are just where we're at now. MRD high risk, event-free survival 81%, relapse risk 14%, MRD low risk, event-free survival 97%, relapse risk 2%. At the moment, it doesn't look like this EFS or this relapse risk changes if you reduce the treatment. We don't know about this, whether or not we'll help with whether there's going to be any difference between the more intensive and the standard treatment patients. Okay, now one thing that's certainly happened since we've adopted CCG therapy and since we've adopted better asparaginase, we were talking about Erwinia the other evening, and all the children in the UK used to get Erwinia asparaginase, which was a lovely drug because although you had to give it by IM injection, it never made the patient sick. But then we realised we weren't giving enough of it, so it wasn't making them sick, but it wasn't very good at treating leukemia either. So everybody now, as Dr. Sharif was pointing out the other evening, now has greatly increased the doses of Erwinase that they use if they substitute it for E. coli asparaginase. But ever since we put the doses up, we've seen lots more toxicity. So we've gone from a situation where ALL treatment for many of the patients was very, very straightforward to a situation where the children keep on coming back in sick. And these are sort of the main problems we see. Obviously we see febrile neutropenia, but then you get that with any cancer therapy. But these are the specific problems that we see. And I was going to talk a bit about pancreatitis. I was going to talk a bit about avascular necrosis of the bone. I was talking about a bit about thrombosis. And if you look at patient deaths, which is always a worry, these are the induction deaths in the first 5 weeks of treatment. So you can see that we've got better at giving the treatment. So although the numbers are always small, you really shouldn't be getting many induction deaths with ALL treatment, obviously. So the induction death rate's gone down from 2% to 1% as we got better at supporting the patients, got used to what the problems were. And there isn't much of a problem with the 3-drug induction, which is the standard risk patients. The problem is obviously with the intermediate and high risk patients who are getting 4 drugs. There's the addition of anthracycline to patients who are in bone marrow failure and are on substantial doses of dexamethasone. And that's produced problems, especially with infection and with fungal infections. We talk about fungal infections a lot, but we never used to see fungal infections in ALL patients. I mean, perhaps we saw the occasional bit of Candida, but nothing else, but now we see Aspergillus as well. So fungal infections are more of a problem than they used to be. These are deaths in CR by treatment regimen, overall 1.5%, and you can see regimen A and B, not many deaths in remission, and that's because, I mean, there's virtually no difference really by then. Well, there's no difference between regimen A and B, but regimen C, which is more intensive for the first year, twice as many or 3 times as many deaths in remission. And it just shows why randomized studies are important, because if we assumed that allocating children with a slow response to therapy would help them, we'd be exposing them to a 3% risk of dying in remission without knowing that it's better for treating their leukemia. So it just reiterates why one needs a randomized study rather than just allocating to therapy. Avascular necrosis in ALL, these are data from the CCG, and I'll show you a slide how this is reflected in the UK. But all these statements from the CCG are true. So AVN is rare in young children. It's quite common in teenagers. It's especially common in late teenage, early adult life. It's more of a risk in girls. And what the CCG also showed was if you gave interrupted dexamethasone in the reinductions or delayed intensifications, you could halve the rate of AVN. So the message there, I think everybody knows, dexamethasone, although it's only a steroid, is actually a very dangerous drug, I think. I think it's one of, in some ways, the way we use it now, it's perhaps one of the more toxic drugs we use. And minor changes, like just not giving week after week of continuous dexamethasone, can make quite a big difference to the children. These are the data from our study, UCAL 2003, just the same as CCG here, 1% AVN in the children under 10. In the children and teenage here, it's up around 10%, with no difference in the patients aged 16 to 21 compared to the patients aged 10 to 15. So that's slightly different to the CCG, but otherwise the message is much the same. But of course in our studies we're using discontinuous dexamethasone anyway. Now pancreatitis is something I can't remember, until about 3 years ago, I can't remember if I'd ever seen pancreatitis before in my life actually. So it's the sort of thing you learn about at medical school, and certainly in paediatrics I'd never seen it. But now we see it relatively frequently. And it's all related to asparaginase, and although steroid may make a minor contribution. And this just shows the range of incidence of pancreatitis, as you see. And it's all, as I said, it's all to do with the intensity of asparaginase. So if you use a protocol like the Dana-Farber study, which uses a lot of asparaginase, and I think your St. Jude study has ongoing asparaginase for a long period of time. So it'd be interesting to hear your experience with pancreatitis. But you can see it's not very common in the under 10s, but it certainly is relatively common in the teenagers. So this is a problem, and certainly we quite commonly now, or quite often, have a child in the ward for 3 or 4 weeks with acute pancreatitis, which causes a fair amount of chaos in the amount of treatment they can be given during that period. And so these are our data again for ALL 2003, 1% of children overall. The problem is in regimen B and C, which have got more asparaginase, 14%, and it's all in, or almost all in, asparaginase-containing phases of therapy. So it's a problem. And finally, thrombosis. These are the Dana-Farber results again. Again, the teenagers are the ones who are taking a battering, 15% thrombosis in the over 10s. I'm not sure if the next slide's got, no, we haven't got ours. But I haven't got the UK data at the moment. I think there may be a reporting problem. We're not quite sure that all the clots are getting reported nowadays. But again, a fair number of our children now are on low molecular weight heparin because they've had a clot with their asparaginase. The other thing we do is we try not to put central lines into the patients until the end of induction, if we can help it, because of the evidence that the chance for clot is higher if you've got a central line and you're given asparaginase. But we always put central lines into patients who are going to have an anthracycline. So all the patients on regimen B have an indwelling line, so they are at risk of clots. But we don't use routine prophylaxis, anticoagulant prophylaxis in our patients, although some people do, and I know in Germany in the BFM they do. I mean, they're great believers in prophylactic low molecular weight heparin in their patients. Okay, now a group of patients we talked about with AML who do really well, provided they survive the treatment, are the Downs children. We've got a different problem in ALL because there's absolutely no evidence at all that their ALL is easier to treat. than other children, but what we do know is they're quite likely to die due to the treatment. And when we looked at our results in ALL 97-99, so it's a CCG-based study, only about half of the children with Down syndrome were surviving. And of the ones that died, half of them were relapsing and the other half were dying treatment-related deaths. And the treatment-related deaths were usually due to mucositis and sepsis. So that's why they were dying. So we need to do something about that. So we discussed it at one of the IBFM meetings, and the Germans said, oh, we don't have a problem, and the CCG said they had got a problem. So we talked to the CCG about what could be done, and the trouble is nobody knows what to do about it, because if you reduce the intensity of the treatment or take the anthracycline out, you probably get more relapses, so that's difficult. You could put the children on prophylactic antibiotics, but never through the anthracycline-containing phases, but nobody's proven it helps. People wondered about fiddling with the steroids, but that doesn't make sense because steroids don't cause mucositis. So it's a bit bewildering how to help these patients. But this slide just shows what's happening. So we've got 45 children, 3 induction deaths, 7 CR deaths. So that's 10 out of 45 children have died on ALL 2003. And these are the causes: 7 bacterial deaths, 2 virals, 1 bleed there. So that's what's happened. So it's how to avoid these bacterial deaths. I think whether or not prophylactic antibiotics make any difference, there's a bit of a vogue at the moment to give the children ciprofloxacin with or without oral augmentin throughout the induction and throughout the delayed intensification. I don't know if that'll work. Certainly these children, if they get sick in any way, need to come back into hospital and start broad-spectrum antibiotics, but certainly 2 children I've looked after in the last 3 years have died, even though as soon as they became remotely unwell, they were brought in and given broad-spectrum antibiotics. So I don't really know how we're going to move forward on this issue, but it's a worry. And if you look at the data, it's actually the case that the Downs patients did better a decade ago than they do now, whereas all the other children do better now than they did 10 years ago. So the more intensive treatments have led to a poor outcome for Downs children whilst improving the outcome for the normal population. So that's a real worry, really. Okay, so as we leave that behind and move on to poor risk ALL now, and on the slide you can see the risk groups I was going to talk about. And one of the things I need to touch on, really, when talking about poor risk ALL is the role of stem cell transplant in poor risk ALL. So this is an analysis from the BFM, so the German, Swiss, Austrian and Czech group, looking at their experience with 637 children. It was published in 2005. And this is looking at their high-risk patients and saying that the event-free survival for their high-risk patients was 41% with chemotherapy and 56% with stem cell transplant. But then if you looked at the overall survival, there was no significant difference between the 2 groups, between chemo and SCT, and that was because it's the same old issue again. The TRM was relatively limited in chemotherapy. It was higher with matched family donors here at 9%, and it was incredibly high with unrelated donors here. So this is, and I know that we published our results in the 1990s, and this is no different really. That's exactly the same thing, that if you take very high-risk ALL patients, you can show a reduced relapse risk with transplant, but there's always the treatment-related mortality that counteracts it, and it really always causes a problem. And it's still not clear, especially if one's running a national or international multi-center study, that one can really get these TRM rates for stem cell transplant down low enough to really get the full benefit from the reduction in relapse produced by the intensified treatment. So, the BFM analysed the data further, and the little stars after the figure, the little stars in the other asterisks, show that these are significant, statistically significant values. So they found there was a significant advantage to transplant over intensified chemotherapy in patients who were not in remission at day 28. You can see 56% here versus 26%. Philadelphia positives, 50% versus 25%. 411s, no advantage. High count T, no advantage. And I think that links back to the slide I showed you with the ALL 2003 results for high count T cell disease, that actually if you get the chemotherapy right nowadays, the results for high count T are surprisingly good. So it's not surprising that SCT doesn't help. So really it's a limited group of patients, failure to remit and Philadelphia positive. But I don't think that's very different to your practice, I think, when I've been talking to people. It's what you do. Okay, so this slide shows event-free survival by cytogenetics. The lowest curve shows the Philadelphias at the bottom here, T922, with the amplification of chromosome 21, IM21 patients at the bottom. And of course it shows the TEL-AML patients right up the top, which is why you with your protocol pull them out of being at low risk of relapse. So these data are the UK experience with Philadelphia patients. They may or may not have changed now, because at the moment there's an international randomized study trying to assess the role of imatinib prior to SCT in Philadelphia positive ALL. It's a hard study to do because as more and more data are published on the use of tyrosine kinase inhibitors in Philadelphia positive disease, doctors and patients are voting with their feet and opting to give imatinib to all the patients. So that's always one of those problems. So whether this study will ever be completed and whether we'll ever get an answer, or whether we'll just end up giving imatinib to everybody, I don't know. I think we might end up giving imatinib to everybody, actually. Yeah, you agree? Yeah, I agree. So there we go. And so of our Philadelphia positive population, 3/4 of them went into remission. You know that achieving CR is quite often a problem with Philadelphia positive patients. 28 out of those 36 got an SCT. Event-free survival 52%, which is just the same as that BFM slide I showed you. But the next bit just goes back again to the fact that they're not all the same, and that response is very important. I don't have there was an MRD slide I could have put in, but it's very, very complicated because it's all sort of points. There's a group of patients, and it's all different points of assessment for MRD during treatment, and whether they were negative or positive, and how it changed. So it's a horrible slide to look at in a talk. But what it shows is that MRD is informative in Philadelphia, as I said before, and this is where morphology is informative. So patients who are rapid early responders to their therapy assessed on what will be the day 50, the day 8 bone marrow, you can see that if they are rapid early responders of a tiny group of 5 patients who are given chemotherapy alone, 3 of them are alive just with chemotherapy, whereas the ones who are slow early responders, who did worse than the ones who are rapid early responders, none of the chemo-only patients survived. So it's quite clear here that if you're a slow early responder and you're Philadelphia positive, you ought to have a stem cell transplant. The rapid early responders, who knows if we can dissect this out, perhaps we can, perhaps they don't all need an SCT, but your response to treatment, a good response doubles your chance of being cured in Philadelphia compared to a slow response, irrespective of the therapy you receive. This group of patients, very small group of patients, so I think this is 19 children out of about 1,600 children, so it's hardly anybody. You're not going to come across it very often. But this is true internal tandem duplication, amplification of chromosome 21 in ALL 97, rather than the TEL-AML patients. But what we found when we looked at this group of patients, I'm not quite sure why it was looked at. It was looked at by our national cytogeneticists. But of the 19 children, they found the event-free survival was only 29%, but then the overall survival was 71%, suggesting that although these patients relapsed, and you can see the relapse rate was 70% at 5 years, they were salvageable by stem cell transplant. So what was taken from that is that treatment intensification helps these patients. What we don't know is how we should intensify the treatment. And I know that Ching Hong Pui at St Jude's believe that MRD helps with that, and that if you look at MRD and the patients are MRD high risk, they should have a transplant, and if they're MRD low risk, they can just have intensified chemotherapy. And we're doing a similar thing. So if this group of patients are slow early responders on morphology or they're MRD high risk, they're pulled out from matched donor transplant. We're not doing mismatched transplants because there were a couple of deaths, and certainly one of my patients died of the transplant. That's obviously a bit of a shame when that happens. So we're only doing matched donor transplants. Otherwise, we'll use intensified treatment, and that's especially important because we don't know that the problem needs SCT. I mean, it may be that intensified chemo is enough, especially because most of these patients in the ALL97 treatment trial were in the standard risk group, so they got very low intensity treatment. So perhaps we'll learn a bit more. The BFM, when they looked at this, found the same thing we did. So it seems to be true that this group of patients are at high risk of relapse. Now, you might just about be able to see the top blue line. This is just an issue about, is there any other way of identifying very high-risk patients? And this is an international BFM study group study looking at MRD at 2 time points. Their time points are week 5 and week 12. And this is using MRD by PCR for IGH and TCR, like I mentioned before. And so they can show that patients, and you can see down here how the patients are divided. So the line here, where there's about 1 relapse, I think, right along the top, these patients are MRD negative at both time points. The next line down here are patients who are positive but less than 1 in 10 to the minus 3 leukemia cells at 12 weeks. And the bottom line is patients who are positive at more than 10 to the minus 3 at week 1 and 2. And you can see they do abysmally. So there is an issue that you can use MRD to select a group of patients who you wouldn't pick up in any other way using MRD, and whether or not in this small group of patients, you can see it's about 14% of these BFM patients, whether these patients ought to be offered treatment intensification SCT in first remission. And there is some evidence that the prognosis may be better if the chemo is intensified and they have a stem cell transplant. So one of the things that's difficult at the moment, actually, it's like we're talking about in AML, it's difficult to know what will actually improve outcome. It's true in ALL as well, and so everybody is interested in trying to help patients at very high risk of relapse, and that's by treatment intensification with or without SCT, and obviously this is a group of patients that everybody's going to look at. And people are wondering how to intensify the treatment, and the drug of the moment is clofarabine. So both in the States and in Europe, people are using clofarabine-based regimens. One of the most popular is clofarabine, cyclophosphamide, and etoposide. That's a study that the CCG closed for a while because they had too many treatment-related deaths. But it's open again now. We've been using it. It seems okay, actually. It doesn't seem too bad. But the biggest problem is clofarabine costs a fortune. That's the biggest problem with it. And whether it'll be any more effective, we obviously don't know. But that's really clofarabine and cytarabine is another combination that people have been looking at, but it's perhaps more interesting in AML than ALL. But those are the sort of, that's the treatment intensification people are going to use, and then probably SCT from any donor, I suspect. Okay, so infant ALL, the slide summarizes the features of the ALL. I mean, obviously, these babies tend to present with a very high white cell count. It's very common for them to have both myeloid and lymphoid features to their blasts. They usually, or often have an MLL gene rearrangement, and it's been accepted that the best way to treat them is with a hybrid therapy with intensive phases that are increasingly like AML chemotherapy. So I wasn't completely clear whether you used Interfont or not. I mean, I think you use a St. Jude's protocol, but it may be Interfont anyway, because I think St. Jude's have been involved in Interfont. So this is the Interfont 99 protocol, which is run worldwide. Which requires the babies to stay in hospital an awful lot in the first 60 or so weeks, well, first year basically, isn't it? We don't have to worry too much about the details through that slide. These are the prognostic factors that have been looked at and found to be important in infant ALL. Age of the child, even though they're all under 1, the older they are, the worse. The older they are, the better the prognosis. MLL gene rearrangements, prednisone response, and presenting white cell count. So this table shows the risk stratification for these children that's been derived from Interfont. So down the left, risk group, low risk, intermediate group, high risk, and these are the factors. So children who have a prednisolone good response are aged over 6 months, MLL germline, are low risk, and you can see the event-free survival is 90%. Children who have a prednisolone poor response, age less than 6 months, MLL rearrangement, have an EFS of 19%, and intermediate here. Now, the other thing that's not on this slide, I've only just realised actually, is the white cell count. And what was decided in the committee for the next Interfont study was not to use prednisolone response to put white cell count in. So this slide's a bit wrong. So you should take prednisolone response out, and the low-risk patients, the patients with a white cell count of less than 300 times 10 to the 9 per litre at diagnosis, and the high-risk patients are the ones with a white cell count over 300. So to be in that high-risk group, it should read white cell count over 300, less than 6 months, MLL rearranged. And we saw a little child yesterday who was MLL germline, was over 6 months, but had a presenting white cell count of over 300, so he would be in the intermediate risk group here with a 50% chance of event-free survival. The other problem is if these patients relapse, there's absolutely no evidence they can be salvaged, really, so the event-free survival and the overall survival are very similar. So the Interfont 2008 study, which has just started internationally, the low-risk patients, so that's the white cell count under 300, age over 6 months, MLL germline patients, get the standard arm of the last study, and hopefully will do very well. The intermediate and high-risk patients are being randomized for post-induction therapy between the previous Interfont study and 2 AML blocks. One of the worries is that the previous Interfont study, after induction, went into a phase called MARAM, which is high-dose methotrexate, followed by a Kapitzi regimen. And there always used to be a risk of relapse in that phase with three high-dose methotrexates. And the worry was that wasn't intensive enough therapy. So there is a comparison in this study between 2 MRC AML blocks, AID and MIDAC, against MARAM to see if intensifying the chemotherapy at that point actually controls the disease better. The high-risk group of patients are eligible for SCT in first remission. The maintenance treatment is just the same, so it's a BFM maintenance with no Vinc-Dex pulses and no continuing intrathecals. So that's the therapy. So we will learn whether adding AML blocks helps, and we'll learn whether SCT helps. So the final part of this talk, and I'm sure you will be very glad it's the final part of the talk, is about relapsed ALL. And obviously this is a significant problem. We don't see it very much nowadays. I mean, certainly, and it shows the way our treatment has changed. In my Friday clinic, which is quite a big clinic, I think most weeks there used to be somebody who turns up who relapsed. And now it's very uncommon, actually, to suddenly find somebody in clinic who's relapsed. So it's been quite a dramatic change in practice. When the new UK R3 relapse study opened, for the first 2 years I never had a relapse patient to put in it. That's come back to haunt me a bit now because I put quite a lot of patients into it, but that's just the way it goes, isn't it, really? Swings and roundabouts. But, so I think relapsed ALL is now a much less common problem than it used to be. But it's still the case that most relapses occur in standard risk children. It's still the case that success of retreatment is limited, it's difficult. There's still this debate about chemotherapy versus chemotherapy plus bone marrow transplantation. We all know that the duration of first remission and the site of relapse are important in determining prognosis, and we know that on treatment, early relapse is especially poor. So because relapsed ALL has become less common, because we can't do a randomized study on our own in the UK, we talk to the BFM because we feel that in Europe the BFM really for many, many years have been the most successful group for treating childhood ALL. And as you know, CCG treatment is basically modified BFM therapy. So it's all linked together, so it seemed a logical thing to do. And we've adopted the German risk stratification for relapsed ALL. And this slide isn't as horrible as it looks. So down the left is time to relapse. So very early relapse, relapse in the first 18 months from diagnosis. Early relapse, anywhere between 18 months from diagnosis and 6 months off treatment, and then late relapse, more than 6 months off treatment. Anybody who relapses at any site in the first 18 months is a high-risk patient. If they relapse after 18 months, but still within 6 months of the end of treatment, they're a mixture of intermediate risk and high risk. You can see that a bone marrow relapse remains high risk. Any T-cell relapse remains high risk. And this is because the German experience was, with very effective frontline therapy, that if patients had a relapse of T-cell ALL, they died. They relapsed early and they died, so that's why they're high risk. And then the late relapse is more than 6 months off treatment. A marrow relapse is intermediate risk. A marrow plus any other site is intermediate risk. An isolated extramedullary, so non-bone marrow relapse, standard risk. Here, even with T-cell extramedullary, standard risk. But any marrow relapse involving the marrow and T-cells, still high risk. So almost all T-cell relapses are high risk, whereas the situation changes for precursor B disease. And we applied this German risk stratification to the UCAL-R2 study, which ran from about when would it be? About 1995, I suppose, to about 1991, something like that. And it shows here how it works. So the standard risk patients, there aren't many of them, but do really well. The higher risk patients do really badly, and the intermediate risks are in the middle, but quite good really for relapsed disease. So the other problem we faced was when we designed the new relapse study, because we felt that we were going to have less relapses having adopted CCG treatment, we assumed that children who relapse were going to do really, really badly because they'd had better treatment as first-line treatment. So we wondered what to do, and we wondered how to use stem cell transplant and how to use chemotherapy in these sort of patients. So what we decided to do was that all high-risk patients should have a transplant. So all those patients have chemotherapy plus a stem cell transplant from any available donor. The intermediate risk children have either chemotherapy alone or combined with SCT, and that depends on their MRD. And the standard risk children receive chemotherapy and local radiotherapy if they need it. And this is how we use MRD in intermediate risk patients. And you can see the MRD is done at week 35. So all these patients have a common intensive anthracycline, steroid, asparaginase, vincristine, cytarabine-based induction. And at day 35 they have their MRD. And if their MRD is more than 10 to the minus 4, they're scheduled for a transplant at week 14. If it's less than 10 to the minus 4, they're treated with chemotherapy. So that's where it splits. In the high-risk patients, they're all going to have a transplant anyway, but we do MRD before the transplant, and if they have more than 10 to the minus 3 leukemia cells in the marrow, they get treatment intensification with fludarabine, cytarabine, and danoxone before they go to transplant. And I think the next slide will show you why that's the case, and that's because our experience is if they're MRD positive at that level, the transplant won't work. So we're hoping that we can get the MRD down before they go to transplant, so the transplant's got a better chance of working. That's an assumption. It may be this is just selecting out really bad acting patients and that nothing's going to work for them, they're going to die of leukemia. But the patients who've responded and their MRD at that time point is less than 10 to the minus 3 just go straight to transplant. And I'm not sure if I got it here actually. Yeah, here I have. It might be this one here. Yeah. This is why we're doing that, is this shows what happens to patients post-transplant based on their pre-transplant MRD level. And so if they've got undetectable MRD, this is a ratio, it's a hazard ratio here, so they're taken to be an equivalence point here. If they're MRD positive at less than 10 to the minus 3, they're still 4 times as likely to relapse as if they've got undetectable MRD, and if they've got high-level MRD, which is greater than 10 to the minus 3, they're 14 times as likely to relapse. This is a problem. So, there's very, very little chance of a transplant curing high-level MRD patients, where there's a reasonable chance for the other children. So that's the problem. This is the outcome after chemotherapy in the intermediate risk group based on MRD, and you can see here that MRD is very informative again, but this is at 10 to the minus 3, so that's what MRD being used for, and that's just duration of first remission and effectiveness of therapy, which is basically SCT. So there are some survivors amongst this high-risk group of patients who are relapsing within 18 months from the start of treatment, but not very many. But the ones who relapse later are not doing badly, actually. About 50% of them are curable with SCT. So there's some hope of achieving something there. So the conclusions are survival for ALL continues to improve, response to therapy indicates groups of children with different prognoses, reduction of treatment is possible for selected children, and there's a question about will intensification help high-risk patients. And I think that's probably the lot. I don't know why it's gone that way. Anyway, never mind. So that's wrong side, this one. Yeah, that's it. Thank you.
Do you use MRD for during follow-up of your patient?
No, we don't. I mean, we send marrows off for MRD, but we don't get the results. Yeah? So it's being measured to see how informative it is, but we don't do any later MRD measurements that change therapy. And it's an important point because some of the patients, obviously especially ones that relapse, will become MRD positive on follow-up. But we're not using it at the moment.
And it's possible that sometimes you change your attitude during follow-up according to the MRD if it is rising, for example?
We're not told it, so we can't change our attitude. I think the one thing we talked about is that it's only appropriate to tell doctors what the MRD result is if it's going to lead to an agreed change of treatment. Because the trouble is, otherwise, if you give the MRD result, human beings are human beings, and if they don't like it, they're a bit tempted to change the treatment. Or if the parents found out about it, and then if you know, and the parents probably have to know, and then they might want the treatment changed. And we found that with the whole study that we're doing at the moment, ALL 2003, parents quite often have quite strong views about what they think should happen based on the MRD results. So some people are all for reducing treatment, some people are frightened about reducing treatment, some people are really keen, if it's high risk, on increasing treatment. Other people don't want to increase treatment because they're worried about toxicity. So you just can't know. So I think we were talking in the last few days about what should be measured in the lab about patients. And I think if it's not clear that an intervention is helpful, those data need to stay in the lab. And then your study coordinators can have those data at some stage, but they shouldn't be going to the clinicians to guide therapy.
So we're having kind of a similar situation here, especially for those who are more intellectual, and they worry so much when you're going to tell the family that your child is going to be changed from the low risk to the standard risk, it's kind of a problem.
Yeah, I mean, what I've found is even the words that are used can really upset a family. Like, we've called it MRD low risk and MRD high risk. Some families have never recovered from being told their child is MRD high risk, even though the relapse risk is really small. Just the word high risk is a nightmare to them. And you can explain it 150 times and they'll never recover. So we're going to have to change the words. But the trouble is then, whatever you call it, they'll go and talk to the other families. And if they find that another family's got what sounds a bit better than theirs, so, well, it's very difficult. It's very difficult.
Any more questions? Tomorrow we have the last lecture of Dr. Webb. It's about adolescent acute leukemia, I think.
Well, I've got 2 more talks, so you can choose what you have.
Okay.
You can have adolescent leukemia, or you can have HLH, or you can have both. So it's up to you, because I can change the slides. You might want to change from leukemia. You might be a bit bored by leukemia by now.
What do you think? HLH?
Yeah.
Okay.
And HLH is a disease that needs transplants, so we'll talk about that as well, and how to do the transplants, all that sort of thing. So we'll do HLH.
It's HLH. I'm just going to give you a very nice خبر, news, is that the lectures of Dr. Webb is now, we succeeded to compile it on the same format of the Cure for Kids of the St. Jude. So, who wants the lectures, we can contact Ahmed Samir. He already prepared 2 of them, and very soon it's going to be on the website. So you can review the lecture again. It's exactly like the same format of the St. Jude. And thank you for Dr. Webb, because he came today because Dr. Ala took him yesterday until 2 o'clock in the morning smoking shisha. Smoking shisha until 2 o'clock in the morning. Any more questions? ممكن بكره نيجي بدري عشان نستوعب ال HLH.
ونشوف النور آخر الطريق. مش بالكلام نقدر نحقق كل اللي بنحلم بيه، لازم نصدق مفيش حلم مستحيل. كلها يوم ونحقق حلم كبير بقاله سنين. نور الشمس ده في قلوبهم ونشوف أولادنا مش خايفين. كون ليهم صديق يلا نكمل الطريق. ايدي في ايدك حلم ولادنا بين ايديك. حلم ولادنا بين ايدينا بس المشوار طويل. لو نجري نوصل أسرع ونشوف النور آخر الطريق. مش بالكلام نقدر نحقق كل اللي بنحلم بيه، لازم يوم نصدق مفيش حلم مستحيل. كلها يوم ونحقق حلم كبير بقاله سنين. نور الشمس ده في قلوبهم ونشوف أولادنا مش خايفين. كون ليهم صديق يلا نكمل الطريق. ايدي في ايدك حلم ولادنا بين ايديك. حلم ولادنا ايدي في ايدك حلم ولادنا بين